Good evening. I think you know today's class is on AION, AION. Because it is an optic neuropathy, before Shamika presents, I just like you to just quickly rattle off the different optic nerve function tests you know. Okay, color vision. Aarti? Never. Pupil evaluation. Pupil evaluation. Anju? Visual field. Amrita? There are 5. The color vision, visual field, pupils. What's remaining? What is the electrophysiological test in VEP? VEP. And one more test. Visual acuity. Okay, so remember always visual acuity, color vision contrast sensitivity, pupil evaluation, fields, and VEP. Now, you should also remember that each one of these optic nerve conditions can be positive in non-optic nerve neuropathies also. So just because one is positive doesn't mean the patient has got an optic nerve thing. Okay, so you need to take your history into consideration and then use these as adjuncts. Okay, so Shamika, we're ready when you are.
Good evening. The topic for today's class is NAION, Non-Arteritic Anterior Ischaemic Optic Neuropathy. I will be your presenter, Dr. Shamika Patoria, and this class will be moderated by Dr. Smita Vittal Praveen ma'am or SV ma'am. We will first start off with a clinical case. A 55-year-old male comes to the OPD with complaints of poor vision in the right eye since 1 year, blurring of vision in the left eye since 1 month. He is a known case of diabetes and hypertension since 1 year and is on treatment for the same. He consumes tobacco regularly, and there is also a history of snoring present.
1 minute.
Yes.
What does the history of snoring signify in ophthalmology? No. What is snoring indicative of? Yes, yes. So, what kinds of diseases can happen in the eye because of sleep apnea? Yes. What glaucoma? Normal tension glaucoma. Okay. Then NAION. Then retinal conditions? Vein occlusions. Yes. Anything else? Bilateral disc edema, snoring, obese, idiopathic intracranial hypertension, and floppy. Yes, floppy eyelid syndrome. Good. Carry on.
On ocular examination, the best corrected visual acuity in the right eye was 6 by 60 N6 and in the left eye was 6 by 9 N6. Color vision in both the eyes was 1 by 21 and it improved with Ishihara with red filter to 17 by 21 in both the eyes. Extraocular movements were free, full and painless in both the eyes and there was RAPD present in the right eye.
Okay, 1 second. So, what book do we use to check color vision? Complete the name Ishihara's pseudo-isochromatic chart. Why is it called pseudo-isochromatic? Venu Hasni. How many of you have had your neuro postings already? You have had. Tell. Anybody? Okay, because what are we basically testing with Ishihara's? We test the red-green color blindness, right? So people who have red-green color blindness, for them, all the plates appear similar in color. It appears isochromatic, but it's not so, right? It's pseudo-isochromatic. Okay, 1 on 21 means the demo plate is red. The first chart is called the demo plate or the test plate, and its purpose is everyone, including people who have color blindness, should be able to read it. So if they're not reading it, either the vision is very poor. So if it's something like hand movements vision, no point sticking the color vision chart under their nose, or they have a very dense central scotoma and so they can't see it, or they're functional. Okay, malingering should always be a diagnosis of exclusion. Even though your gut feeling says this chap is lying, don't go ahead and say it just like that, okay? Because they all have underlying psychological disturbances. And Ishihara with red filter. Many times in neuroopthal, you will see cases which say 1 on 21 OU, 6 and 6 OU, normal fundi. Okay, color vision 1 on 21 becoming 21 on 21 with red filter. What does that mean? Everything is normal. The color vision becomes 21 on 21 with a red filter. It means the person is colorblind. Okay, color blindness affects men or women more? Men. What condition can women get colorblind? Find out. Okay, yeah, carry on. One more thing quickly, because this is the first class in neuro this year. RAPD. How do we grade RAPD? Hussein? Okay, in SN we follow 4 grades.
Ma'am, first grade is when the pupil constricts first and then dilates. Then second grade is, ma'am, pupil is still and then it dilates. And if the pupil directly dilates, then it is grade 3. And the pupil fixed and dilated, then it is grade 4.
But because this is not at all objective, right? You might say it's grade 2, I may say it's grade 3. So is there a better way of quantifying RAPD? What is that? Neutral density filter. Very good. So we'll talk about that in some other class maybe. Okay, please go on.
Face examination, no anomalous head posture was present.
Okay. Why do we talk about anomalous head posture? Where do you see AHPs, Anju? Any acquired palsy, cranial nerve palsy. Then ptosis, bilateral ptosis, not unilateral ptosis, bilateral ptosis. Then that you already said. Acquired strabismus of whatever reason, bilateral chin up, then bilateral ptosis, torticollis, and one more. More than that, nystagmus. Okay, why in nystagmus do you have AHP? No, there's something called null point. Do you know what null point is? Yeah, that is the particular area where the nystagmus is least in terms of amplitude and frequency, and the visual quality is best. So that is why they develop a AHP. This I've just asked them to put this. I've asked you to write this whole slide, though not required in a neuro case. You can just say anterior segment normal, but make this a habit. Make this like a template for all the cases that you present in your exams. Okay, body, face, and then eye. So she should have actually started by saying patient is moderately built and has normal vitals, which becomes important in a case of NION. Then face examination, very good, no anomalous head posture. Slit lamp. Always make it a habit to say lid and adnexa because that includes a sac. Most of you will forget to talk about sac when you're presenting cases. So when you say lid and adnexa, you're safe. Okay? Yeah.
This is the fundus drawing and the fundus picture. On the in the drawing on the in the right eye, we can see a pale disc, and retinal pigment alteration is seen at macula, and the retina is attached. In the left eye, there is sectoral disc pallor with luxury perfusion, which is seen on the inferior aspect.
Does anybody know what luxury perfusion is? It is a term that's used only in the context of NION. Luxury perfusion. That particular part of the optic nerve is the healthy optic nerve and it looks redder than normal, right? So this is your assignment for today. Find out what luxury perfusion is and is it a good thing or a bad thing? Okay? We'll talk about it when we come to altitudinal defects. Okay? Not all NIONs develop luxury perfusion, but if you use the term, it indicates NION. Yeah.
These are the Humphrey visual fields of the patient. On your right hand side, you can see the left disc, and this is the right disc. In the right disc, corresponding to the optic atrophy seen in the previous picture, there is a well established inferior altitudinal field defect. And in the left disc, the inferior altitudinal field defect is still developing.
It's left eye and right eye because disc is only blind spot. Okay? The whole fields is basically the entire eye.
Yes.
Your visual field. Okay? Yeah. So can anyone tell me what the point of intersection of the vertical and horizontal axis that corresponds to what in the eye? The macula, right? The fovea. What does the horizontal axis correspond to? Horizontal raphe. Above and below that, you have your papillomacular bundles, which is why your glaucoma field defects will be arcuate around that region. Okay. So now you tell me, why is the field in? Are we talking about it later on? Altitudinal defects in our theory? We could. Okay. Go ahead. Go ahead.
These are the OCTs of the patient. On the right hand side is the retinal nerve fiber layer OCT, which shows a severe thinning of the RNFL in the right eye and a moderate to severe thinning in the left eye. The ganglion cell complex OCT shows severe thinning in the right eye and moderate to severe thinning in the left eye. A neurooptometric evaluation was also done for this patient. PRISM trial was done for field expansion. Investigations done for this patient were MRI brain and orbit, which showed thinned out optic nerves and small vessel ischemia. And on carotid Doppler, there was no stenosis. A sleep study was also prescribed for the patient. Management was done in the form of strict diabetes and hypertension control, and a field expander trial of prisms was given.
Okay. So to summarize, basically it's sequential loss of vision, painless sudden loss of vision, one eye followed by the other a year later almost. Okay. And going by all the investigations, what is your most likely diagnosis? This is a class of NION, so it's going to be bilateral NION. Okay. But um, the investigations that we have ordered basically comes under something called the ischemic workup. When you're very sure that it is only ischemic related condition you're dealing with, ask for an imaging. It could be a CT or an MRI. Usually indications are always for MRI in neuroophthalmology. If you're very sure it's an ischemic event, CT can be advised. A carotid Doppler, but just to rule out carotid artery disease, and we'll see why we wanted a Doppler. Sleep study because we want to rule out sleep apnea. Risk factors of NION. Can you tell me other causes of sudden painless loss of vision? Optic atrophy is always a sign, it's not a diagnosis. No. All arterial occlusions, whether it's CRAO, BRAO, ophthalmic artery occlusion. Then Retinal detachment. Very good. And Wittem. Good. These are the main ones. Okay. Wittem, retinal detachment, all arterial occlusions, and AION. Okay. Go ahead.
So coming to the
Yeah,
diagnosis,
we'll skip this.
now to understand the disease entity of NAION better, we would like to discuss the anatomy of the optic nerve. So the optic nerve can be divided into four parts, which are the intraocular, intraorbital, intracanalicular, and intracranial. The intraocular part is the smallest part, which is 1 mm, and it is the part which is seen inside the eye as the optic nerve head. Behind it is the intraorbital part, which is the longest part, which is present inside the muscle cone and is 25 to 30 mm in length. The intracanalicular part lies inside the optic canal and measures about 5 to 9 mm. And from there on starts the intracranial part, which ends at the optic chiasm and is 10 to 16 mm in length. Moving on to parts of the optic nerve head, the optic nerve head can be further divided into four parts, which is these four parts are divided on the basis of the presence of the lamina cribrosa in the sclera. So the first part is the surface nerve fiber layer. The second part is the prelaminar layer, which lies above the lamina cribrosa. Third is the laminar layer, and fourth is the retrolaminar layer, which lies below the lamina cribrosa. Moving on to the blood supply of the optic nerve head, which is very important in cases of NAION. So the first layer, which is the surface nerve fiber layer, gets its blood supply from the retinal arterioles, which are a branch of the central retinal artery. They also get branches from the posterior ciliary artery, which is the cilioretinal artery. The prelaminar region gets its blood supply from the short ciliary arteries. The lamina cribrosa is supplied by short posterior ciliary arteries and arterial circle of Zinholler, which is comprised of long and short posterior ciliary arteries.
How many short posterior ciliary arteries might an eye have? Always a range, right? So 6 to 12 at least.
The retrolaminar region is supplied by ciliary circulation and retinal circulation. The ciliary circulation gives the centripetal branches from the pial plexus, and the retinal circulation gives centrifugal branches from the central retinal artery. Moving on to anterior ischemic optic neuropathy, it is the commonest cause of unilateral optic nerve swelling and optic neuropathy in adults greater than 50. Any case of ION can be divided into different entities based on anatomical differentiation and physiological differentiation. Anatomically, it can be divided into anterior ION and posterior ION. The anterior ION comprises of the intraorbital part of the optic disc. Therefore, it presents as optic disc swelling, and the posterior part involves the anterior part involves the intraocular part of the optic disc, and posterior involves the intraorbital
It's
part.
easier to remember if you say what is the anatomical structure that differentiates these two, anterior and posterior? Lamina cribrosa. So anything that happens ahead of the lamina cribrosa, anterior. Anything that happens retrolamina is posterior.
And physiologically, it can be divided into arteritic and non-arteritic. Arteritic involves inflammation of the artery, and non-arteritic, which is more common, does not involve inflammation of the artery.
Okay.
So a classical presentation of NAION would be in the form of acute, unilateral, painless loss of vision, and the vision loss is maximal when noted and often does not progress. There are no prodromal ocular symptoms associated with it. If there is presence of prodromal amaurosis fugax or diplopia, it should increase the suspicion for temporal arteritis.
So another word for amaurosis fugax would be transient vision loss, right? So what are the common causes of transient vision loss? Migraine, number one. Then not necessarily ocular migraine. TIA, TVL is a form of TIA. Okay, fine. Then retinal guys, raised ICP. Okay. Then carotid artery disease. Then thromboembolic phenomenons, which will affect you guys, retina people. Okay. It's easy to classify TVLs if you know the duration also. You can find out or guess the etiology. So a TVL, a transient vision loss that lasts only for a few seconds and is postural, usually leads to raised ICP. If it is for a few minutes, could be carotid artery disease, especially if it occurs after meals or if it occurs after exposure to bright light. If it lasts not more than half an hour, and may be associated with scintillating scotomas, migraine. And if it lasts for hours together, then thromboembolic phenomenon. And there's one particular TVL called gazed evoked TVL. That means the person will tell you, I'm reading a book and I say quickly, sometimes I miss a few letters and it comes back for a few seconds, the vision is gone. That is a sure shot indication for imaging the orbit, because there must be an SOL there which is compressing the optic nerve. The intraorbital portion is very long, right? So at the apex, there might be an SOL which is pressing. It is S-shaped. So when the eye moves laterally, it allows the eye to move laterally because the optic nerve is S-shaped. But if there's an SOL, it will compress. That is gaze evoked TVL. Okay, so TVLs never seen in NION.
The signs which are associated with NAION are reduced visual acuity, dyschromatopsia, which is defective color vision, relative afferent pupil defect, and disc edema, which is usually pale and sectoral, with splinter hemorrhages and dilated capillaries on the disc surface. The visual field loss associated is mostly inferior altitudinal.
Okay, so now let's talk about the field. Do you want to talk about something else here?
The pictures.
Okay, go ahead, go ahead.
These are splinter hemorrhages. These are the dilated capillaries or the luxury perfusion. And this is the diffuse disc swelling with cortical spot.
Okay, so why is the visual field loss altitudinal? You can now answer. I want to hear the word that you used that time. That's the right answer. Because the optic nerve is a dash dash.
There is a watershed area that is created.
Yes.
When the short posterior ciliary artery enters, it divides into a superior and an inferior part. So that is why.
Because the optic nerve head is a watershed area, so all the blood vessels that go there only distribute to a particular area. That's it, right? So you get an altitudinal field defect. It's not that always it will be an altitudinal defect. Many times it may be even constricted. Okay, but on the whole, any kind of optic neuropathy can produce any kind of field defect. Okay, 1 minute. Go back. Yeah, what is diabetic papillopathy? That will also look like this: disc edema with splinter hemorrhages and all. How do you differentiate diabetic papillopathy from NION? More, we have something called NION of the young also. No, start with history. Which patient will come to you with history of sudden painless loss of vision? NION, right? Not diabetic papillopathy. Diabetic papillopathy, vision is usually 618 or better, and even if the vision is less, it's often because of a maculopathy, not a diabetic, not optic nerve problem. Then, which patient will have RAPD? NION. Okay, diabetic papillopathy will not. Which one will be only one at a time, whereas one can be bilateral simultaneous? Diabetic papillopathy can be simultaneous, but NION can only affect one eye at a time. It will always be sequential, never bilaterally symmetrical. Which one will be associated with other NPDR changes? Papillopathy. Which one will have a field effect? NION. Okay, so that's how you differentiate. Diabetic papillopathy basically just requires you to have strict control of diabetes. It takes about a month to 10 months for it to resolve completely. If not, 50% of papillopathies can go into full-blown NION. Okay, NION will investigate. You'll do everything that's required, like imaging and Doppler and things like that. What is incipient NAION? Just like you have impending CRVOs, right? You have incipient NION. So that's your second assignment. What was the first one, Vansh? No, luxury perfusion. Oh God, you guys. Not even 15 minutes. Okay. Go ahead, go ahead.
When we talk about NAION,
1 second. Go back. Let's ask if someone already knows this. 3 times you've shown the slide. What is Foster-Kennedy syndrome?
There is a atrophy of one optic disc and the other optic disc appears dilated. In papilledema, in atrophy in other eye. Space occupying lesion. On the side of the optic atrophy. Side.
Which part of the brain?
Anterior frontal lobe, anterior lobe,
or
anterior cranial fossa.
olfactory group.
Olfactory.
Okay, frontal lobe or olfactory group. Why does this become important? Because then you ask the history of smell. You have unilateral anosmia. You can have that because it is in the olfactory group. Yes. And then she's now going to talk about
pseudo-Foster-Kennedy syndrome is a similar presentation, but in normal MRI without a space occupying lesion.
Most common cause of pseudo-Foster-Kennedy is Now you can show off.
as already discussed, pseudo-Foster-Kennedy syndrome is when there is a previous attack in the other eye leading to a pale disc along with ischemic swelling in the newly affected eye. Whereas a true Foster Kennedy syndrome is when there is visual loss due to a compressive optic atrophy in one eye and papilledema in the contralateral eye due to increased intracranial pressure caused by an intracranial space occupying lesion.
Okay, so by definition, papilledema is bilateral disc edema secondary to raised ICP. Everything else is just disc edema. Okay, when you say papilledema, I'm going to assume that the pressure in the brain is raised. So you can't have just one eye papilledema. Here, you can get away by saying that because it is raised ICP. Okay, once a disc is pale, it doesn't swell. That is why optic atrophy in one eye and papilledema in the other eye. Otherwise, you can actually say disc edema in the fellow eye.
Moving on to the pathogenesis of NAION. Although the pathogenesis of NAION remains unknown, there is a hypothesis that is proposed, which is the hypoperfusion of the posterior ciliary arteries. So, hypoperfusion of the short posterior ciliary arteries leads to the ischemia of the optic nerve head, which in turn leads to edema of the optic nerve head, and there is obstruction of the axoplasmic flow, which leads to infarction and apoptosis of the retinal ganglion cells. This leads to further edema of the optic nerve head, and there is a picture of a compartment syndrome which is formed due to the swelling of the nerves at the rigid lamina cribrosa. There is compression of the optic nerve head microcirculation, which leads to further ischemia of the optic nerve head, and a vicious cycle is set up. Causes of hypoperfusion of the PCA can be in the form of nocturnal arterial hypotension, crowded disc, impaired autoregulation, perioperative rise in IOP, and vasospasm. There are various risk factors which are proposed in the pathogenesis of NAION. These can be divided into systemic risk factors and ocular risk factors. I, um, I forgot to mention, hypoperfusion can be in the form of decreased blood supply to the optic nerve head or decreased oxygenation of the optic nerve head. Therefore, the perfusion of the eye is determined by the mean arterial pressure minus the IOP. Therefore,
That's called perfusion pressure.
Yes.
Yeah.
So, any disease which causes the mean arterial pressure to reduce or the IOP to increase would cause the perfusion pressure to reduce. So, in arterial hypertension, there is arteriosclerosis of the vessels, which causes the inflammation of the tunica media and tunica intima, which causes the lumen of the arteries to reduce in size, which reduces the overall supply to the optic nerve head. In nocturnal hypotension, this can be usually physiological, where there is a dip in the blood pressure when a person sleeps, or it can be due to antihypertensives that might be taken at night. In diabetes mellitus, there is a systemic microangiopathy, which leads to decreased blood supply. And in hyperlipidemia, it could be due to atherosclerosis of the vessels. Smoking also causes damage to the vessels. And obstructive sleep apnea, as discussed, can cause transient stoppage in breathing, which leads to hypoxemia in the body. Anemia also leads to decreased oxygenation of the disc, and migraine causes vasospasm in a lot of vessels. Ischemic heart disease causes decreased blood to reach to the to the optic nerve head, and systemic medications like phosphodiesterase 5 inhibitors like sildenafil and amiodarone cause a systemic hypotension.
Is there anything that's missed out here that we test for routinely when we're checking a case of NAION in SN? What do we do when we do the ischemic workup? No. Blood test. Homocysteine. Nice. Homocystinemia. Okay? Because blood becomes sluggish.
The ocular risk factors can be disc at risk.
What's a disc at risk? Small crowded disc. So whenever you're seeing a case of NAION, always comment on the cup of the fellow eye.
Optic disc drusen and perioperative rise in IOP.
Why would optic disc drusen cause NAION? Localized compression. Is optic disc drusen a risk factor for some other cause of vision loss? Suppose you have optic disc drusen with peripapillary hemorrhages? No? Optic disc drusen with peripapillary hemorrhage is not very common, but that is called peripapillary CNV. Okay, that is also a risk factor. Okay.
Moving on to the clinical course of the disease. The clinical course was studied in detail by two studies, which were the IONDT series and the HERE series. The IONDT stands for Ischemic Optic Neuropathy Decompression Trial. In this, 258 patients with acute NAION and visual acuity worse than 20 by 64 were studied. The visual acuity observed at 6 months were as follows: 43% patients showed improvement, 43% showed stable visual acuity, and 14% worsened. In the HERE series, 340 patients were studied, and the visual acuity at 6 months showed 40% improvement, 40% had stable visual acuity, and 20% showed worsening. Better visual outcome was seen in patients presenting with visual acuity 6 by 18 or better. Risk of recurrence over 5 years was the same eye showed 3 to 6% chance of recurrence, and in the fellow eye, there was 15 to 25% chance by the HERE series and 15% chance seen in IONDT series. Future risk of vascular events. Conflicting results were seen in various studies. Studies by Here and Lee showed that there was increased risk for subsequent central nervous system and cardiovascular system events, whereas the studies by Park and Foster suggested that there was no difference. Coming to the treatment, till date there is no effective treatment for NAION, but a few modalities which were tried were aspirin, steroids, intravitreal triamcinolone, intravitreal bevacizumab, intravitreal erythropoietin, and surgically optic nerve sheath fenestration or radial neurotomy was tried. Although none of these showed any evidence that they were effective, either as preventive treatment or as treatment of the disease. So the management of the disease can be in the form of checking the erythrocyte sedimentation rate or the C-reactive protein. This is to help differentiate between NAION and AION. In AION, usually ESR and CRP will be highly raised. And AION is one of the causes of medical emergency where giving systemic steroids
Can save
as
the
soon
other
as
eye.
possible
Basically,
can
the whole
save the
purpose is
other
to
eye.
protect the other eye. How
Yes,
soon
ma'am.
does the other eye get affected in arthritic ION? Within 1 day to 14 days. Okay, so you have to protect the fellow eye. Unfortunately, many people come when the second eye gets involved. Other than arthritic ION, what are the other manifestations in the eye of GCA? Ocular manifestations of GCA? Go read about that because that's a different class. Yeah, go ahead, go ahead.
We will try to control vascular risk factors like hypertension, diabetes, hyperlipidemia. We must try to avoid antihypertensive administration at night to avoid nocturnal hypotension. And a medication review is needed in cases of phosphodiesterase 5 inhibitors and amiodarone. We need to rule out carotid disease to rule out any thromboembolic disorders. And neuroimaging like MRI brain orbit and CT brain can also be helpful. Sleep study is given when indicated. Uh, Now, to briefly differentiate between non-arthritic and arthritic AION, the age of the patients in non-arthritic is usually 60 to 70 years, but in arthritic, it is rare to find any person affected under 50 years. They are mostly over 70 years of age. There is no race preponderance in NAION, whereas Caucasians are more commonly affected in AION and African Americans are less commonly affected. There is no sex predilection in NAION, whereas more commonly women are affected in arthritic as seen in many other connective tissue disorders. Preceding systemic symptoms are not seen in NAION, whereas they are common in AION, which can be in the form of scalp tenderness, headache, or jaw claudication. Preceding ocular symptoms are not present in NAION, whereas they are common in AION in the form of transient visual loss or diplopia. Pain is rare in EION, whereas it is common in EION since there is presence of inflammation of the arteries. Vision loss can be minimal to severe in NAION, whereas it is usually severe in AION. Simultaneous involvement of eyes is extremely rare in NAION and can be occasionally present in AION. Second eye involvement is 15 to 30% months or years in NAION, whereas it is a whopping 75% within days or weeks. Disc appearance shows sectoral edema, and in AION, it may be normal or chalky white swelling. Sedimentation rate or ESR is less than 40 in NAION and usually greater than 90 in AION. The FFA seen in NAION can be normal or can show delayed optic nerve head filling, And in AION, it is usually choroidal filling defects are seen. Anatomic predisposition is seen in NAION in the form of small crowded optic nerve head, whereas no such anatomic predisposition is seen in AION. Other signs of ocular ischemia are not present in AION, whereas they can be occasionally present, such as in the form of transient visual loss or diplopia. Late optic atrophy presents as simple pallor in NAION and presents as cupping in AION. And response to steroids is not seen in NAION, whereas there are definite systemic response to steroids in AION, and vision can show improvement.
Okay, why does the disc look pale? What contributes to the pallor?
Ganglion cell death.
Yeah. So loss of tissue volume, then ganglion cell death and proliferation of astrocytes. So the disc suddenly becomes pale instead of being nice and pink. Something called Kestenbaum number. Nobody's going to ask you in real life like that, but sometimes in exams, some old timers might ask you, what is Kestenbaum number? It's something to do with capillaries on the optic nerve head.
These are the references which I used. Thank you.
Well
Thank you,
done. Big clap for Shamika. First class. Well done.
Thank you, ma'am.